All right, so this patient gets referred to you guys. It's a patient who's had ICL. So a little bit of history on them. One of my friends texted me and he said, "Hey, we have this patient who has ICL and they're really light sensitive." And I would say, like, usually, if somebody's light sensitive after ICL, like normal in the first week, you use your steroid drops for about a week, but then it gets better, right? Unless they have maybe a really high vault and their pupil's a little bit bigger, in which case I've seen either you can rotate it vertically and that will lower the vault, or you can exchange it for a smaller sized ICL if that works with all the calculations. But in this case, he said, "Bobby, it's kind of a little bit interesting. They have some transillumination defects." I'm like, "Oh, that's really uncommon with the ICL, even though the ICL sits in the sulcus and it rubs up against the posterior pigment epithelium. It's very uncommon to have it release pigment, like very uncommon. Like you can see it before with the legacy ICL, with doing iridotomies, or sometimes dilating a patient for the first time, it just released pigments. But to look like this, it's like, what's going on?" And he was like, "Man, we just have a series of 3 of these cases. They all look like this. And the question is, what do we do for this patient? Is it the ICL that's causing this? Like, what could be causing this?" So the patient came over, and I saw the patient, and I looked in, and this is the first thing I saw, and I was like, "Oh my goodness." Uh, yeah, that's interesting. And then here is the other eye. You can just see how much transillumination defects are there. So, any thoughts?
Injections. Did
This
they
is about
use?
this is about just like some time frame. Like we're seeing them like at a month, and this all started about 1 week.
So what's the pressure? First question.
Normal.
Any intracameral injections in surgery?
Yeah, so that was so when we were looking at this, Becky, like what we were looking at was like, what does the vault look like?
Hmm.
Like, is it the vault? I mean, I don't know. This looked like the most perfect vault ever to me. It was like, goodness, what's going on? So we started asking a little bit more about like the history, like, well, what's going on? And they said basically they did their steroid drops, everything finished, but when they got off their steroid drops, they had some like rebound inflammation, which I've never seen a case of rebound inflammation. Like after cataract surgery, yeah, all the time. After ICL, I've never seen that. So I thought, huh, that's interesting. So I started
My
typing into Google, like transillumination defects.
my one thought actually, so you kind of gave it away there, but I thought that I had this could be an inverted lens because then it would be pressing up the wrong way, but it
Yeah,
looked like it wasn't.
it's not. It's not.
Okay.
Inverted
Okay.
lens would be the opposite way, but this is great. Yeah, you get your nice
Yep.
uh vault over the yes. That
Yeah.
would
If
be
it
on
were
the
inverted.
differentials.
Yeah.
The other thing was that their pupil was dilated. So this patient is actually, this is not me dilating them. This is how they came in.
Uh, you're at Zervalia.
Right. So that's what we were thinking
I've
is
seen
like,
two this month.
wow. Okay. Anu, can you tell us a little bit about that?
So it's essentially, but then I would expect a higher pressure. So it's possible they were like a steroid, like a super responder. At some point it was super high, and that's why the pupils super dilated, and then you get these residual effects. Although even for that though, that's a lot of transillumination.
So how do you say it, Anu? In Canada, how do y'all say it?
How do we say you're at I'm gonna say this wrong now. You're at Zervalia?
Yeah. I don't know how to say it. I would say like Art
Zavala?
Zavala or something like that. I don't know how to say it.
I don't know.
But
Between us, we'll figure out the
yeah.
pronunciation.
But that's where the pressure is really high in the first 24 hours. It could be usually it's from visco, or it could be a really high vault that closes the angle. The pressure is really high. The sphincter gets ischemia, and you're left with a blown pupil basically. But you see here, it's like it just wasn't making sense. So, like I usually do in the wee hours of the nights, just started Googling, trying to figure out what was actually happening with this patient. And this patient had bilateral acute iris transillumination syndrome, BAIT or called Beatty, where patients can have an allergic reaction to moxifloxacin. Patients can get an allergic reaction to moxifloxacin from oral moxifloxacin, from topical moxifloxacin, or around this time, what happened is there was quite a bit of surgeons around the US who had intracameral moxifloxacin, and that's the reason why Becky was asking that question, intracameral moxifloxacin, that then they were having this allergic reaction, and then this is what the eye looks like. And so the question was like, well, do we leave them in? Do we take them out? Their vision's corrected, but it's really just this allergic response. This is my own opinion. I haven't proven it, but I think it was a bad batch of moxifloxacin from wherever people were getting it from. But now you've seen surgeons at the end of cases for because this mainly happens this in surgery for phakic patients, not necessarily seen after cataract surgery patients. I've heard of it once, but I haven't seen anything in the literature on it. but I don't know if it's like a higher concentration and it all stays in the front of the eye and causes this to happen to the iris. So really interesting case here. But oftentimes if you see kind of any kind of like, it's not often, I mean, you're gonna rarely, this is something that goes on our differentials.
Does
So
this
interesting
one at
case
all
here.
do like if you put some Pilo in there, would it respond?
It didn't do anything, but that was the first thing I tried.
And is it getting any worse? I mean, presumably because it's just a reaction, then you could just leave the ICL there. It's not doing anything. Think about a pupiloplasty.
Yeah, it's a great question. So I had around the same time after we got sent these, I had a personal patient who had this, and I didn't, and then I finally figured out what it was. But what happened was they had a little bit of transillumination defects, and then they had more, and then they had more, and then like it settles down like at about 2 months is what I've seen, and that's what they're left with. But yeah, I mean, like, what do you then try? Do you do a color contact lens? Do you do, I don't know, whenever it comes down for cataract surgery, do an IOL and the iris special iris implant that goes inside the bag to help cover some more of this?
So
Do
we've
you put
done both of those as or all three of those as options. You can do like an aniridia contact lens to see if it helps. Often they don't respond to Pylos. You can't really do that, but you try it first. The patient we had actually just, it's funny you say it comes down around 2 months because I think they were referred to us at about 2 to 3 months and it was pretty stable. And we ended up just doing a pupiloplasty. They're super happy with their vision. Their vision was 20/20 plus, and but they were just very light sensitive. So yeah, ended up working out well.
So what'd you end up doing with this patient, Bobby? You're still trying to figure it out?
Well, this patient went back to where they came from. It was like a 3.5 hour drive. And ultimately, this patient just elected to monitor. And they were at the time undergoing some contact lenses to try to see if that could help with them. Like if we think about like a normal cornea and an iris, okay? And then if you think about a cornea with somebody who has pigment dispersion where the iris is concave and goes back, and it's
Mm-hmm.
concave and goes back, and then you have your lens zonules. And then like here you have your crystalline lens. And in pigment dispersion, I know I'm interested in your opinion here. The reason why you get transillumination defects with pigment dispersion is because the zonules are rubbing up against the concave iris. So what if we were able to separate those two? And how could we do that? Well, what in these
Put an
patients, they're
ICL.
myopic. What if you put an ICL in to actually lift up the iris from the lens zonules? And what if we actually treated pigment dispersion syndrome with
Could
ICLs
be
to
help.
prevent the pigment from chafing?
I've done that. We have done that, actually. We have a patient who has pigment dispersion syndrome. He's a 39-year-old guy. He came in for an ICL eval, and his pressure was 38, just completely off the cuff. And I was like, "Holy cow! Hold on a sec." And I talked it over with my partner, Dr. Vukic, and we're kind of like, same, that theory exactly holds true. Or it's a theory, but it does make sense. Where if you can lift that up, it will help. And we still manage his glaucoma. He's still on drops, and he will be for a long time until we kind of do our next round of procedures.
Yeah.
But he's steady. He is holding steady, and there's no new TIDs. I mean, but he is holding steady. That theory makes sense. So for this patient too, I was thinking. I mean, Bobby, with your drawing, actually, I think that really helps conceptualize what's happening with PDS. Doing a PI, I mean, that in theory would help, but in this case, it probably wouldn't. In this case,
Are you
doing a
talking about
PI,
for a PI for pigment dispersion?
yes, yeah,
Okay.
yeah. So
Do you
you could
believe
do.
in that? Do you believe in PIs for pigment dispersion?
I believe that I've been taught that it's okay.
No. Anu, what about you? Or do you believe in those or no?
We don't typically do them for that, but we will do them post like other like IOL procedures and things like that, where you have that reverse concavity, um,
Okay.
or
Yeah.
reverse pupillary block, I should say.
Yeah, I'm like, the literature hasn't convinced me, even though it makes sense. It's like, oh, okay, it makes sense. The thing that makes the most sense is ICL. So I think we just got to catch all our pigment dispersion early enough to where the pigment doesn't go into the trabecular meshwork and treat them with ICL. So that's just Bobby's opinion only. But I have actually only seen one case report of this in the literature. It was presented at a meeting, and I can't find it since then, or else I would put it in here. But
I will present my patient at one of our next ones, but I'm not advocating that we use ICL to treat PDS. However, you
I am.
can do it in these.